So we talk about patellar dislocation and how to avoid or prevent recurrent dislocation of patella. So what are the main stabilizers of patella? And what are the factors that govern the stability of patella? Tell me.
Bony factor is the trochlear.
Very good. So patella dislocation. So if the patella is dislocating laterally, what are the main components for that? So one is a soft tissue component and one is a bony component. So very good. So you were telling about bony components. So what are the bony components? So trochlea is the most important. Trochlea. So trochlear asymmetry or trochlear dysplasia is the one very important cause. Anything else?
The rotation malalignment.
So version issue.
Version issue.
Version is one issue. Very good. So version is with respect to hip. So antiversion. So antiversion may be increased. So that can lead to a intorsion of the femur. Femur. So what happens is version is one issue. Then when patellar height. So patella alta, if there is a patella alta, that is an issue. And there is one more issue which is called as a we call it a Q angle कह सकते हो, or you can tell it as a tibial tuberosity insertion malalignment. So that is called as a TTTG distance. So what is that? Why that is important is because if your trochlea is like this and the tibial tubercle is laterally here, so then there is a lot of forces acting laterally on the patella. So increased TTTG distance is a factor. So trochlear, if you talk about sequence, soft tissue, that is the MPFL. Now what is MPFL? So what is it? Have you seen it? What is MPFL? Is it like an ACL PCL ligament?
Condensation of the retinaculum.
No. Retinaculum is different. Medial retinaculum, lateral retinaculum is different. What is MPFL? Medial patellofemoral ligament. What is that? MPFL ligament is basically a capsular thickening. So it's a thickening of the medial capsule, and specifically on the, so this is from the patella. So this is the patella. It goes from the patella to the femur. So it is like that. It's a thin layer of the capsule which is thickened. The capsular layer, if it is thickened, this is MPFL. And then there is a from the quadriceps tendon also. So people call it a MQFL, that is medial quadriceps femoral ligament. Basically, it's a sheath of tissue which originates from the quadriceps tendon and the patella, and it goes up to the femoral. So it's basically a thickening of the capsule, and this is a very, very flimsy structure. It's not a rigid structure like your ACL, PCL or MCL, LCL. They are not tense ligaments. It's a very, very thin layer which is thickened. So if you see in the arthroscopy, you will see just a condensation of capsule. So this is the soft tissue. In the bony tissue, the most important part is the trochlea. That is, trochlear asymmetry is most common. And if you see the classification, you know who gave the classification of trochlear dysplasia? There is a type A, B, C, and D. Type D is the worst type of dysplasia. So you should read that classification. That is very important. But the trochlear dysplasia is an important cause because instead of a concave trochlea, these patients will have a convex trochlea, and then the patella will slide on the lateral side very easily. Then the TTTG distance is another very important region. After that there is patella alta. So this is 1, this is 2, this is 3, and version will be 4. And valgus also is one of the important areas. So if the valgus is there, the TTTG distance will be more, and that will lead to more chances of dislocation. So these are the most, I can write valgus also. So fourth part probably is valgus, fifth is valgus, inversion. So most of these cases, if you have a bony anatomy which is normal, then it is a soft tissue injury, and then usually these patients are traumatic. So these needs to be addressed with MPFL surgery. Now MPFL surgeries, there are a number of surgeries which are described. So people are doing MPFL reconstructions. You can do reconstruction with quadriceps tendon. You can do reconstruction with semitendinosus, gracilis, and there are many techniques which are described for an MPFL reconstruction. I personally do a technique which is called as an MPFL advancement or MPFC advancement, in which we advance this layer of tissue on the patella. So basically we tension the layer. So this is a published technique. This is called as an MPFC advancement. So if I think the patient is a soft tissue injury, I will do a MPFC advancement. You can do an MPFL reconstruction if you want. If you want to do a bony procedure, then you do a trochleoplasty, but it is less performed surgery because it's a little bit complicated surgery and not as easy or simple. And the other is a tibial tubercle osteotomy. Now there are three kinds of osteotomy. So osteotomy, what happens is, this is a supposedly this is the tibia and this is the tubercle. Okay, so you can do three types of migration of the tubercle. You can do anteriorization of the tubercle, you can do distalization of the tubercle, and you can do medialization of the tubercle. Okay, so you can do three changes. You can medialize the tubercle, distalize the tubercle, you can anteriorize the tubercle. So if there is a patellar instability because of increased TT distance, you do medialization. If the patient is having pain also, you do anteriorization, because anteriorization will deload the patella. And if there is a patella alta, you do a distalization. Okay, so you have to see if there is a patella alta, increased TTDG, you do anterior medialization, distalization, both, or medialization or distalization if there is no pain. Okay, so whenever you do tubercle osteotomy, you need to see medialization, anteriorization, distalization, depending on the symptoms that the patient has. And very occasionally, you will need to do a procedure for version and valgus, that is a femoral osteotomy. Very rarely you will have to perform a procedure which is a derotation osteotomy of femur or a corrective osteotomy of the femur to correct the valgus. So very rarely you need to perform this procedure. So most of the procedure in my cohort, if you see, approximately 60% patients will be MPFL alone. 60% patients will be MPFL alone. Approximately 20% patients more will need MPFL along with tubercle osteotomy procedure, anything. And then approximately 20% is rest, everything included. Okay, so that is trochleoplasty or femoral osteotomy or something like that. So this is what is basically the surgical procedures that are needed for a patellar dislocation. Now what I want you to do, go and read about types of trochlear dysplasia. You must read that. There is a classification, Dichor's classification. You should read the classification. Types of trochlear dysplasia, how to identify the types of trochlear dysplasia, and specifically what procedures can we do, and types of trochleoplasty. We will discuss in detail later. But by and large, this is a rough idea that you should know about recurrent patellar dislocation, approach, and how to treat it. But you should go home and read this, specifically types of trochlea, types of trochleoplasty, classification of trochleoplasty, TTDG distance, how much it is normal, how much it is abnormal, and how much when you want to do what. So these are the things that you want to